Hey there, Platypi. Welcome to another lecture in your series for gastrointestinal system. Today, I'm going to be trying to cover all of the anatomy that you will require or need to know for this semester. And it's going to be a bit of a big presentation, I'll admit. There's a lot of slides to get through, a lot of content to go through, but I promise that it'll be quick and painless. And I'll also try and make sure that I focus only on the actual clinically relevant or at least examinable content rather than all the superfluous information that might be available elsewhere. So I've tried to make it as condensed as I can. But of course, I want you to also think critically and focus on what parts you think would actually be relevant to your exam at the end of the year. So let's get started. Now, before I actually go into the anatomy itself, I just wanted to give a bit of context in terms of where we are sitting right now in terms of your anatomy teaching for this year. So I'm not sure if your booklet looks similar or different to the ones that I've screenshotted here, but your anatomy, at least for gastrointestinal and abdomen, is actually split up into 4 sections. So the first one kind of focuses on anterior abdominal wall, scrotum, and general abdominal features, which is something we would have covered in our lectures from last week. And then you've got abdomen 2 and abdomen 3, which focus on the actual gastrointestinal tract. Now, this delineation between the upper and lower gastrointestinal tract is not too important, or at least not a simple way of going about doing things, just because if you have a look at the topics underneath them, there's quite a bit of overlap and there's no real reason to distinguish it between upper and lower. So what I've done today is I've kind of taken a little bit of content from the abdomen 1 session so that we can wrap that up. And I've also put together a list of slides for the actual organs within the gastrointestinal system that should cover these 2 middle topics. Now, this last topic, which is under abdomen 4, which is kidneys and posterior abdominal wall, I've covered half of that today. So posterior abdominal wall, just because it fits nicely into topic 1 here. But I haven't covered kidneys because that technically comes under the renal system, which we will be covering in a couple of weeks' time. And so look out for that when that comes out. But of course, remember that the kidney is still technically an organ that's found within the abdomen. It's just not really part of the gastrointestinal system. It's more part of the urinary system. All right, now with that out of the way, let's get right into the content. I should say as well, very, very quickly that because this is not designed to be all encompassing, or the content is not going to have all the fine details that you will require or need to know, I've actually put a link to the notes that I've published on the PS Platypus Drive in the comments for this slide. So if you want to cross-reference everything I'm saying with that, as well as check out some of the extra information that's provided, feel free to do that. And let me know if you have any feedback regarding those notes specifically. All right, let's start with section 1, which is the abdominal wall itself. Again, we're going to be hinting back to our lecture from the previous week, sorry. But there will be some extra bits of information here that are useful to know. So very quickly, I want to focus on the peritoneum. Now, if you would have watched our lectures with the respiratory, you would remember that we covered the pleura. The peritoneum is exactly the same thing. In fact, they're all the same sheet, but in this case, we just call it something different because it has its own regional name. So with the peritoneum, we have the parietal peritoneum and the visceral peritoneum, as you can see in the diagram below. Parietal has a somatic nerve supply. It's well localized. It can feel pain, pressure, temperature, whereas the visceral peritoneum has autonomic supply. It's very poorly localized because of its autonomic nature, and it's only really sensitive to stretch or chemical irritation. Now, more importantly with the abdomen than with the thorax is the fact that you've got a distinction between the relationship that organs have with the peritoneum itself. So when I call an organ intraperitoneal, it means that it's covered on both sides or pretty much all sides with peritoneum. So if you have a look at the diagram that's at the bottom, and apologies for the fact that it is quite small, you can see that the jejunum has been put as an intraperitoneal organ because of the fact that on pretty much all of its sides, it's covered by the peritoneum or the visceral peritoneum. With organs that are considered to be retroperitoneal, and again, this comes back to a bit of embryology. So if you're stuck on why these are called the way they are, just have a look at that lecture and it will make a bit more sense. But these retroperitoneal organs are only covered anteriorly. So if you have a look at the ascending colon, which is labeled as retroperitoneal, you'll see it's pretty much stuck all the way back on the posterior abdominal wall. So the only bit that's actually covered by peritoneum is the front. Now, there's an easy mnemonic way to remember your retroperitoneal organs, and that is the mnemonic SAD pucker. So S is for suprarenal, which would be the adrenal glands. A is for the aorta plus the IVC. D is the duodenum, only the first part though. The rest of it is intraperitoneal. P is for pancreas, but not the tail. And that's again, going back to the rotation of the pancreas during embryology. U is for the ureters. C is for the colon, only the ascending and descending parts. And K is kidney, E is esophagus, and R is rectum. Now, there's also this additional term, secondarily retroperitoneal, and that's just organs that have gone from an interperitoneal position in embryology. And within the embryo itself, it's managed to move retroperitoneally. In other words, the way I like to think about this is it was inside the abdominal cavity, just kind of suspended in the middle. And then eventually it shifted all the way to the back, got stuck to the posterior abdominal wall, and then only the front was covered with peritoneum. So a really, really easy way that I've thought of to remember these secondarily retroperitoneal organs is using the mnemonic chosen to be drawn posteriorly. So it makes sense, right? It was in the middle, now it's drawn posteriorly during embryology. So C is for colon, and again, ascending and descending. D is for duodenum, again, only the first part, and P would be for pancreas as well. Like here, it's important to remember it's not the tail. Okay, so chosen to be drawn posteriorly. All right. Now, the bit that kind of confuses a lot of students is when we discuss the spaces themselves. And this slide aims to kind of just give you a really quick, good summary that will help you a lot when you get to the exams. So when we think of spaces, we like to divide the peritoneal space, or at least the abdominal cavity, into two sacs. The greater sac, which as the name suggests is a lot larger, it's composed of the supracolic and infracolic parts. So it's not really that clinically important, but the main thing is the fact that the colic bit is referring to the transverse colon. Everything above that is supracolic. Everything below that is going to be infracolic. The lesser sac, or the omental bursa, as it's sometimes called, is behind the stomach. And you can see it in this diagram here, where you've got it connecting to the greater sac via the epiploic foramen. So again, a really easy way to think about this is the fact that the greater sac is sort of everything in front, it's massive, and obviously it's not really filled with anything apart from potentially a bit of fluid, whereas the lesser sac is actually behind the greater sac, and it's a really, really small bursa right here, okay? And it's connected to the greater sac via this hole, the epiploic foramen. This lower diagram here is just to show you that the lesser sac also has its own borders. So if you want to remember this, that's totally fine. It's not that important. I've seen it come up in one exam, but it's just a good idea to keep in mind that the epiploic foramen has these four borders around it, formed by the IVC, the caudate process of the liver, so just a bit of the liver, the first part of the duodenum, as well as the free margin of the lesser omentum, which contains the portal triad, which we'll go over in a couple of slides' time. Now, when it comes to recesses, the main reason we discuss this is because they are actually also dependent spaces. This means that if you were to have some sort of fluid accumulation in the abdomen, and say you were standing up, it would most likely collect in those dependent spaces because of the force of gravity. But of course, it's not just when you're standing up, because if you're lying down, there might also be recesses there. So you want to be really careful with, if you're given a clinical scenario and it says patient has some sort of problem, fluid has accumulated, which recess is it most likely to have accumulated in? You want to think about, first of all, are they sitting or standing? And secondly, where has the pathology occurred? Is it more around the liver, or would you think it's going to be more around the pelvis that you'd expect the accumulation to happen? So the 2 or 3 main hepatic recesses are firstly the hepatorenal recess, which is also called Morrison's pouch. That's the one that is super buzzwordy, and that's the place where you will find the majority of accumulation because it's the deepest sort of recess that there is when the patient is supine. And then you've got the minor ones, so subphrenic and subhepatic, which are all illustrated in this left-hand side diagram there. The pelvic recesses, of course, are in the pelvis. Now, because of the fact that you've got different organs or internal organs for males versus females, you will also have different recesses between them. So with a male, you only have one pouch or recess, which is called the rectovesical pouch. As the name suggests, it is between the rectum and the bladder. So vesicle meaning bladder. This is the place where you will find the accumulation happening if a male patient had fluid and they were sitting up or standing up. With females, they also have they have 2 main pouches. The main one that they will actually get accumulation in, though, is the rectouterine pouch. It's also called the pouch of Douglas, and it's much deeper then the other pouch, which is still the uterovesical or vesico-uterine pouch. So the other one here, as you can see, a lot less deep, and it's a bit more shallow. All right. Then the second most confusing thing is actually figuring out what all these names of the peritoneum are. So the peritoneum itself stays the same. It's just that when it folds on itself or when it does all sorts of things regionally, it starts to get different categories. So when we think about the omentum, the greater omentum and the lesser omentum are the two things we're talking about. You can kind of see them illustrated here. You can see the greater omentum is kind of like a bit of an apron that covers the entire small intestines, large intestines underneath the stomach. And then the lesser omentum, which is actually composed of the hepatogastric and hepatoduodenal, they actually cover the lesser sac that we talked about before. So you can see that here in green, okay? So we'll cover the actual ligaments themselves in a couple seconds, but the main thing here is not to actually get bogged down in the anatomy of it all. It's just to remember that when I say the word omentum, there are two types, and which ones are they? That's the main thing you need to know. The greater omentum is cool because it's actually the normal omentum folded on itself, the normal peritoneum folded on itself 4 times, which is why it's a little bit thicker, but it also has a bit of an immunological role. So if you have, for example, a ruptured appendix, the omentum sort of, like if you have a look at a video, it's pretty fascinating. The omentum actually tends to migrate towards that area to try and enclose and heal up to prevent sort of sepsis and things like that. So very, very interesting, and it's a point of research. With regards to the actual ligaments themselves, these are just folds that have occurred twice. So instead of like 4 times or 5 times, it's only twice. And each organ sort of has its own ligaments attached to it. So I've kind of tried to color code it as best as I can. And these are not all the ligaments, but they're the main ones that can be examined. So for example, if I was to say in an exam, what does the hepatogastric ligament contain? You know that that's going to contain the gastric arteries. The easiest way to go about doing this is just to think about, firstly, when I say hepatogastric, I mean between the liver and the stomach, right? So you can see hepatogastric labeled on the diagram there. And just think, what arteries would you expect to be in that area? Okay, so for example, gastrosplenic, or actually I might pick an easier one, splenorenal. So splenorenal between the spleen and the kidney, right? And this is mostly going to be on the left-hand side because the spleen is on the left. What would you expect to be there? Well, once we cover the vasculature, you'll realize that the splenic vessels are going to traverse across the splenorenal artery. So it makes sense that it contains those vessels. Same thing with all of these. The 2 main ones that I would recommend you remember is the hepatoduodenal, because it contains the portal triad on its free edge, and the splenorenal, because it's quite, as soon as you hear splenorenal, you think splenic vessels. So, even in an exam, if you get one of these names, just remember that they're named such that it's very easy to tell where they are. And then you can try and make an educated guess in terms of what could be there. So they connect organs to organs, or they can connect an organ to an abdominal wall, plus they're named based on what they touch, as I said. All right, now you've covered this already. So it's a very brief overview in terms of the fascial layers and the muscles that you're going to find in the abdomen. So we first start with the fascia. Of course, above the umbilicus, you have kind of all the fascia fused together. But when you go below the umbilicus, you get a distinction between campus and scarpa fascia. So camper on the outside and scarpa on the inside. When it comes to the muscles, I've just listed some of the major ones that, it's a good idea to know that they exist, as well as some of their major actions, but you don't need to go into as much detail as you would have, for example, with musculoskeletal system. So anteriorly, you have the rectus abdominis and pyramidalis. Pyramidalis is very, very minor. The lateral walls, you have the oblique, so the internal and external oblique muscles, and transversus abdominis. And then posteriorly, you have the iliopsoas muscle, which actually is 2 muscles combined together, psoas minor, which is, as its name suggests, not that important, and then quadratus lumborum. Then you've got the rectus sheath, right? So you've got the arcuate line that is the anatomical line that is midway between the umbilicus and the pubic symphysis, if you were to draw it on yourself. The difference is that above the arcuate line, you have anterior and posterior sheaths for your muscles. So what I've done here is I've included a diagram that kind of shows you what that looks like. And the anterior and posterior just means that they've been split on to the front and to the back of the rectus abdominis muscle. So you can see here that you've got your three major muscles, which is going to be external oblique, internal oblique, and then you've got the transversus abdominis, but they are not all going in one direction. And the main thing is just that the internal oblique splits around the rectus abdominis muscle. So if you were to actually insert, for example, a needle straight through this wall here, I've put the order of what that would look like. So you have external oblique, the front part of the internal oblique, then you'd hit the rectus abdominis, and then you again hit the internal oblique, but this time the part that went behind, and then the transversus abdominis all the way at the back, and then the more posterior layers. Below the arcuate line, you've got a very similar thing. The only difference is now everything is at the front. So the internal oblique does not split anymore, and everything just goes in front of the rectus abdominis. So you have a very simple scenario where you've just got external oblique, then you've got internal oblique, transversus abdominis, rectus abdominis, and then everything else behind it. So just to contextualize this, everything behind it, when I say that, is just going to be the transversalis fascia. So behind the rectus abdominis or the transversus abdominis. Then you've got fat, and then you've got the parietal peritoneum, visceral peritoneum, organs, etc. Now, when it comes to the inguinal canal, I like to try not to, overcomplicate this too much, because there's so much detail that you can go into. There's a whole lecture that you could get on an inguinal canal and inguinal canal related pathologies. But I just want to simplify it here in terms of the major borders that you should have in mind, as well as the pathway and the contents through the inguinal canal. So when it comes to the borders, there's a nice mnemonic here called RAF-MALT, which is roof anterior, floor posterior. And they each kind of link with either muscles, an aponeurosis, ligaments, or tendons. You don't need to go as far as actually remembering what the muscles are or what the aponeurosis is, because it's unlikely you'll be asked that point blank in an exam. But it's still just a really good idea to know these for your specimens and imaging related things. In terms of pathways, you've got the deep ring or the internal ring, which is, if you were to palpate it, it's above the midpoint of the inguinal ligament. And it's formed by the transversalis fascia kind of rolling in on itself. Then the superficial or external ring is superior to the pubic tubercle, and it's formed by the rolling up of the external oblique muscle. Now, of course, why is this all relevant? The reason why is because we have all sorts of inguinal hernias, and it's important to be able to distinguish between the two different types of inguinal hernias, the indirect and the direct, where they come out of. Do they use the superficial ring or not? Do they go through the deep ring or not? What kind of things can you use to differentiate between them? That would have been covered in a previous lecture, but if you want more information, again, it should be in the linked notes. And then finally, the contents. You've got the spermatic cord in males, which you can kind of see the contents of that within this diagram here. In females, you don't need a spermatic cord because you're not transferring anything down to the testicles or the scrotum. So you just have a round ligament. And then in both males and females, you will have the ilioinguinal and the general branch of the genitofemoral nerves. Now, some important surface landmarks just to keep in mind. Remember that there are two ways you can split up the abdomen. You can split it up into quadrants, which is probably the easiest way to do things. So right upper, left upper, right lower, left lower. It's a very easy way to describe which organs have been affected, or at least where a patient might be experiencing pain. And another more complicated, but also more specific way of delineating different parts of the abdomen is through this system here. So you split it up into 9 regions. You've got the hypochondriac regions, which are just under, like as the name suggests, hypochondriac being underneath those ribs. Epigastric, so around where the stomach is. You've got the right and left lumbar regions, which we just call the flanks. You got the umbilical region in the middle, and then the iliac regions on either side lower down, and then hypogastric. So below, like way below the stomach is where that region is. So that's where you would find the bladder. And then the transpyloric plane, it's actually not that important clinically. The only thing that it's important really for is imaging. So if you know that you're at the level of the transpyloric plane, which would be around the L1 vertebral body or L1, L2, this is the area where you're going to find all sorts of things. And probably the most important things you'll find are the pylorus of the stomach, as the name suggests, right? Transpyloric. You've got the second part of the duodenum, and you've got the hilum of each kidney, as well as, it should say here, yes, the origin of the portal vein. So all of those major things have been shown in this little pictorial representation here. You don't have to remember all of these things at all. I definitely didn't, and they don't really ask this stuff. But when you get to imaging, it's just a good idea to know what things to expect when you're at the transpyloric plane. Now, when it comes to the nerves and the dermatomes of the anterior abdominal wall, it's quite straightforward. There's only really one nerve type that you need to know about, which is the thoracoabdominal nerves. So these are the T7 to T11 anterior rami. They pass between the internal oblique and transversus abdominis muscles, as you can sort of see in this Netta picture here. Now, the easiest way to think about this is that this is the same everywhere. So if you think about the thorax, we know that the intercostal nerves there, they sandwich between the inner and innermost intercostal layers. It's a similar thing here. So if you think about what is the inner muscle and what is the innermost muscle of the abdomen, those would be the internal oblique and transversus abdominis, because the external muscle is the external oblique. So again, if you can draw those parallels, it makes remembering this a lot easier. And then finally, remember, it goes from posteriorly from the spinal cord. It kind of wraps around the sides of the abdomen and then comes out the front, and it produces these nice dermatomal strips that you can see here. So very straightforward compared to everywhere else in the body. It just goes T1, T2, T3, all the way down to T11, T12. The easiest ones to remember are the level of the nipple, which is T4, and the level of the umbilicus, which is T10. And I've just added subcostal nerve because it's kind of different to the thoracoabdominal nerves in the sense that it's a bit larger, but it's essentially the same thing. It's just going to provide you with the T12 anterior ramus nerve. Now, the posterior wall nerves are a bit more complicated. And again, you don't need to really remember all of these in too much detail. But when it comes to specimens, and I've seen this come up in a couple of exams, when they give you a section of like a dissection, and they want you to identify specific nerves in this area, it's good just to know the general order in which they go from sort of lateral to medial. So I've kind of ordered them as such over here. So you've got the iliohypogastric nerve all the way laterally. So you can see that there. That's the L1 level posterolateral gluteal skin in the pubic area. The ilioinguinal comes next, so it's a bit more medial. Again, it's L1, but it provides mainly sensation to the anteromedial thigh. It's one of those nerves that is more likely to be damaged during inguinal hernia repair just because of the region or area in which it's located, which will lead to loss of sensation, but it also supplies parts of the external genitalia. So you might have problems there as well. The genitofemoral nerve comes off L1, L2. It's the only nerve, and this is very, very important when it comes to specimens. It's the only nerve that passes over the psoas major muscle. So you've got the psoas major muscle here. You can see the genitofemoral nerve is the only one that passes over it. So if they label that nerve, you know exactly which one it is because none of the other nerves do that. It branches off into two branches. So the genital branch to the cremaster muscle in the scrotum and the femoral branch, which goes to the thigh muscles. Not so much like not a similar sort of innervation as the femoral nerve proper, but it still has some innervation in the thigh muscles themselves. These also have a lot of, I guess you would say, cutaneous innervation, but that's not too important to know. I guess if you just remembered this diagram here, which shows that cutaneous distribution, that's enough for the purposes of year 2. And then you've got the lateral femoral cutaneous, which is the L2, L3 nerve roots. It supplies the anterolateral thigh down to the knee, and it can be trapped under the inguinal ligament in some pathologies, but it's very, very rare for this to be involved in any sort of problems. Just remember that these are the 4 main nerves that you'll have. Of course, you also have bits of the lateral and sacral plexus around this area, but this would have been covered in lower limb. So if you want a bit of a revision there, just have a look at our slides from back in lower limb, and that should cover most of that, that content. All right, and finally, just some important arterial supply and lymphatics or lymphatic content. It's not too important for you to know this, but I guess if you remember the major branches of the descending aorta, so remember the descending aorta sort of comes down here, forms into the iliac arteries then split up into external and internal iliacs and so on, going down into the lower limb and the gluteal region. You've also got other sort of arteries there, so like musculophrenic, superior epigastric. You don't need to remember what they supply, just know that they exist and that they branch off of the main descending aorta. Lymphatic drainage wise, again, this image contains a bit more information than you would ever need. The main interesting thing I wanted to show you was the relationship with the umbilicus. So if you have any pathology that is above the umbilicus, it will tend to drain upwards into the axillary group of nodes. Whereas if you have any pathology that arises below the umbilicus, they're more likely to drain downwards into the superficial inguinal nodes. And then you've got a similar distinction with above the iliac crest, below the iliac crest, but those are not as important as the umbilicus, because I've seen a couple of questions come up on it when it comes to lymphatic drainage of like cancers or infections. All right, so that's the first part done, which was basically an overview of what you would have already covered from last week with a couple of extra tidbits here and there. But now from here on out, it's going to be completely new stuff. So we're going to actually go into the organs, and I've kind of tried to split this up into two major types of organs. So one is going to be the gastrointestinal tract proper. So that's actually the organs that go from mouth to butt, whereas the other organs, which are called the accessory organs, I've split up separately. So things like, you know, the liver, the pancreas, that kind of stuff has been put as separate section. So let's start with the esophagus. I'm purposely skipping the mouth because that comes under head and neck next semester. So we're going to start straight away with the esophagus. It can be divided into three main regions for imaging purposes, so cervical, thoracic, and abdominal. In terms of muscle layers, which we'll go over more in histology, it actually consists of an external longitudinal layer of muscle and then an inner circular layer. This external layer, though, it is different in different divisions of the esophagus. So at the beginning, so when you start up, it's going to be more voluntary because you can imagine this is the part where swallowing is happening, which is something you control. Whereas when you go lower down, it starts to transition into smooth muscle. And that makes sense because you're not controlling what happens with the esophagus all the way down in the abdomen, right? That happens sort of by itself, all that peristaltic movement. In terms of sphincters, you've got two. You've got the upper sphincter, which is the anatomical one, whereas the lower sphincter is physiological, and it's more going to be directed by the contraction and relaxation of the diaphragm. And the major important thing when it comes to specimens and imaging is the constrictions. So these are physiological narrowings of the esophagus, but also places where you are more likely to get food getting trapped or slowed down. So a nice way to remember this is A, B, C, D. So A is at the level of the arch of the aorta, and it's in the thoracic region, so T4, T5. B is the left main bronchus, T4, T5. C is going to be at the level of the cricoid cartilage in the neck, which is in the cervical area, C6. And then, of course, the diaphragm because of the contraction. So as the esophagus passes through the diaphragmatic hiatus in the abdomen, there is going to be some expected level of restricted lumen, which is at T10. Now, the reason why you get these constrictions is because all of these named anatomical structures, they push against the esophagus. So it's not just because that they're at the level of the arch of the aorta, it's because the arch of the aorta itself tends to push against the esophagus as it passes behind it. All right, now I've lumped together stomach, duodenum, and small intestines because this is really the level that you need to know when it comes to anatomy. The stomach has four main regions. So the cardia, that should say cardia, not cardiac. So cardia, fundus, body, and the pylorus. So from top through to the bottom. Superiorly and inferiorly, we've got the lesser and greater curvatures. And this actually harks back to things you would have covered in embryology. So the reason why we've got these curvatures in the first place is because of that weird sort of rotation of the stomach when it was in the embryo. It also contains folds, or what we call rugae, on the inside. And that the main purpose of that is to increase the surface area. And if you eat a lot, it will also allow the stomach to expand to accommodate for that level of food. Now, interestingly, the stomach is unique because it actually contains three muscle layers instead of two. And that's because it includes an oblique layer. Why is that important? Because it allows the stomach to actually contract in all three planes. So X, Y, and Z planes. And that is good for optimal churning because what's happening in the stomach is you want to get all that food to be digested nice and well, so that when it gets down to the small intestines, they're all churned up so that you can actually absorb all the nutrients that come out of that food, if that makes sense. When it comes to the duodenum, it's made of four main parts. So you can see sort of, yes, it's one continuous bit, but you've got sort of like one part that goes straight across, then it goes down, then it goes straight across, and then it goes across again. So that's going to be between the stomach and the jejunum. The main thing to remember here is that the common bile duct, which we'll discuss in a couple of slides time, empties into the second part of the duodenum. So you've got 1, 2, 3, 4. It empties into the second part, which is the part that sort of goes downwards here. And then finally, you've got the small intestines, which consists of the jejunum and the ileum. The jejunum tends to be thicker, it's heavier, and it has more capacity for absorption of the nutrients. Whereas the ileum, it only really selectively absorbs a couple of things. So bile acids, B12, a little bit of fluid, but that's pretty much it. Because what the ileum does is actually more an immunological role, which is why when you see it in histology, you'll actually see a lot more lymph nodes, a lot more fat around that ileum structure. Now the cecum, appendix, and large intestine. So the cecum comes next. It's the most proximal part of the large intestine. Basically, as soon as the small intestine enters the large intestine, it hits the cecum first. It's found in the right iliac fossa, or the right lower quadrant. Inferiorly, it's a blind-ended pouch. So it kind of has this lower bit here, which doesn't really contain much apart from the appendix that comes off of it. But it's just a blind-ended pouch, so it doesn't do anything. It connects to the ascending colon superiorly. And what separates it from the small intestine is the ileocecal valve, and that prevents reflux of the contents of the colon back into the ileum. The appendix is an interesting one. So the function of the appendix is not really well known. It might have an immunological role, but we're not really sure. The main thing to know anatomically here is that most patients would have a retrocecal positioning of the appendix, which means that it's kind of like, if you think about what that means, it's kind of wrapped behind the cecum. Some patients will have, pelvic positions. There's so many different types of positions you can have, but most patients are retrocecal, which is why when you have appendix pain, it tends to be around McBurney's point, which we will cover when we get to clinical examination of the gastrointestinal system. But that's the main reason why. Whereas if you have patients with different positionings of the appendix, you might get different signs altogether. The large intestine is composed of four main parts. So you've got the ascending colon, the transverse colon, descending colon, and then the sigmoid colon. There are two bends which happen at the hepatic and splenic flexures, or you can just call them the right colic flexure and the left colic flexure. The large intestine also contains its own muscle, which is called the tinea coli, and that's three longitudinal muscles, as you can sort of see in orange over the red on this diagram there. Now, when those muscles contract, it forms the haustra, which is important for absorption of nutrients within the large intestine, which we will cover in physiology. But the important thing to remember is that these haustra are not circumferential. Whereas if you look at the small intestines, they have these things called valvulae conniventae or plicae circularis. Either name is fine. Both names kind of tell you the fact that it actually goes around the entire small intestine, the small bowel, which is why when you actually have an abdominal X-ray, it's very easy to tell the difference between the large and small bowel. Of course, apart from the fact that the large bowel will be peripheral, whereas the small bowel will be more central. But you'll cover that more in detail in imaging. You've also got paracolic gutters on either side of the ascending and descending colon, which is just where fluid can collect when you've got some sort of pathology. And the transverse and sigmoid colon have more mobile mesentery, which means the mesentery that actually connects it to the posterior abdominal wall is a lot longer and it's a lot more flexible. So those parts are actually more prone to having volvulus, which is where basically the intestine just kind of wraps onto itself. It can lead to obstructions and all sorts of bad stuff. Now, finally, we get to the end of the gastrointestinal tract proper, which is at the rectum and the anus. So the rectum, really nothing more to say apart from the fact that it's pretty much the end. It has a sacral and anorectal flexure, so just little bends, but again, not really that important for you to know. With the anal canal or the anus, it's the ending of the GI tract. It has columns which join with sinuses that secrete mucus, which eases the passage of feces through. The pectinate line is something that we would have covered at a lot of detail when we got to embryology. It's very, very important because there's probably going to be one or two questions on it. And the reason why is because it separates the ectoderm from the endoderm. It's also called the dentate line in some textbooks. And remember that the ectoderm is inferior, so it's the outside, and the endoderm is superior on the inside. The internal sphincter is involuntary and it surrounds the superior 2/3 of the anus, whereas the external sphincter is obviously the inferior 1/3, it's voluntary, and it fuses with the puborectalis muscle, which you will cover when you get to pelvic anatomy. Okay, now let's get to the accessory organs. So starting with the liver, I'm trying to go from most important to least important when it comes to examinable content. So you've got the lobes of the liver, and there's two ways you can think about it. First is anatomical lobes. So you've got two main lobes, which are obviously the left and the right. you can see over here that they're separated by the falciform ligament. So the ligament over here, and you've got one lobe here, one big lobe here. The accessory lobes are called the caudate and quadrate. You can see them sort of in the middle there. So you've got this one here, which is the caudate, which is closer to the IVC. And then you've got the quadrate, which is closer to the gallbladder. What separates them is the porta hepatis, which we will cover in a little bit of time. The functional lobes, they don't really have any anatomical differences. The reason why they're called functional lobes is because if I was to rip one of them out, obviously I wouldn't rip it out. It would be for some sort of surgical procedure. The other 7 hepatic segments would still be able to function fine because they have their own, like innervation, they have their own vasculature, they have their own lymph nodes, etc. So it wouldn't cause excessive bleeding if I was to take out one of those hepatic segments. And that's shown here. So they've blown up the liver to show those 8 different bits. Unless you're specializing in this sort of surgery, it's not important for you to know at this stage, which ones are named or numbered as they are. But the main thing to know is that if I was to resect one of these, it would be totally fine. Ligaments wise, the liver has a lot of ligament attachments. The main ones are the falciform, as I mentioned previously, the coronary and the triangular ligaments. You don't need to know exactly too much about them, just the fact that they do attach to the liver. Some other things to consider as well are the bare side of the liver, so the part that is actually in contact with the diaphragm and it's not covered with any sort of visceral peritoneum. The lesser omentum also attaches to the liver, and the inferior vena cava is actually kind of, if you have a look here, it's attached, it's almost embedded into the liver by some this fibrous material there. So it's really important to know that these relationships exist. Then we get to the gallbladder and the biliary tree. So the biliary tree, or actually before I do that, the gallbladder, you don't need to know anything at all about the different parts of the gallbladder. Like it has its own fundus and body and that kind of thing, but it's not relevant at this stage. The biliary tree is very, very important though. So the biliary tree is responsible for taking bile from the gallbladder, the liver, taking enzymes also from the pancreas, and transporting all of those into the intestines where digestion can happen. So again, the role of bile is covered more in physiology. Over here, we're just going to talk about the pathway of the bile. So you've got your left and right hepatic ducts from the liver that takes that bile, which is produced in the liver, into the common hepatic duct. Now, if you're not really eating anything, then all of that excess bile can actually get transported back up through the cystic duct and into the gallbladder for storage and concentration. However, when you do require that bile, this gallbladder gets squeezed. All that bile goes back through the cystic duct, down into the common bile duct, and then joins up with the pancreatic duct. The pancreatic duct will contain all forms of digestive enzymes. So the main point here is that you've now got bile, pancreatic enzymes, all of them come together, and they join up at the ampulla of Vata, which then go into the sphincter of Oddi. So these all have their own kind of weird names. Sphincter of Oddi, which, as I mentioned previously, is in the second part of the duodenum, and it kind of joins in more medially. You've also got the porta hepatis, which is basically taking everything into or out of the liver. So all the important vasculature and things like that. So the porta hepatis contains literally everything that is in the list there, except for the hepatic veins. So it's really important to remember there's a difference between the hepatic veins and the hepatic portal vein, which we'll go over in a couple of slides' time. So the porta hepatis is a triad. It contains your hepatic artery proper, your hepatic portal vein, and then your hepatic bile duct. And all of this is going to be in the free edge of that lesser omentum, as we mentioned previously. Finally, you've got Callett's triangle, which is just it's more surgically significant. Again, not important for us to know too much about. But if you imagine, actually, it's probably better to look up a diagram of this because it's not really well shown in either of these diagrams here. But the main thing is that it contains the right hepatic and cystic arteries, as well as the first lymph node of the gallbladder. When it comes to surgery, it's useful because when I'm doing a cholecystectomy, I don't want to accidentally cut one of the cystic arteries or the hepatic artery because that's going to cause a lot of bleeding. I just want to cut the ducts, right? So if I want to ligate that, and this sort of triangle allows me to more effectively identify which one is which and not confuse either of them. All right. When we get to the pancreas, very, very simple. When you get to physiology, you'll know all about the pancreas and its functions. But in terms of anatomy, it contains the head, the uncinate process, which is, again, going back to embryology, the neck, the body, and the tail. Now, the tail is really, really close to the spleen or the hilum of the spleen. So a lot of people say the tail sort of tickles the spleen. And if you have a cancer in the pancreatic tail, it can compress parts of the spleen, which you can imagine what the consequences of that might be. The head of the pancreas is quite important as well, because that is in close relation to the bile duct. So if I have a cancer in the pancreatic head, I'm going to compress the bile duct. Bile is not going to be able to get into the small intestine, and suddenly I end up with obstructive jaundice. And then finally, the remnant of the dorsal bud, which I'd encourage you to look back on the embryology lectures for what that is. If that stays there and it's not obliterated in a lot of patients, you get an accessory pancreatic duct, which empties into a minor duodenal papilla independent to the main duct. So you can see the accessory duct all the way up here, and you've got the main pancreatic duct down here. Again, not that important to know, but if you are in a surgery and this patient is unique, they have these two things inserting into the second part of the duodenum, you know that there's a reason why. It's not pathological. It's just because something happened in embryology which did not obliterate that accessory duct. When we get to the adrenal glands, so there's a reason I'm not covering the kidneys themselves, because we will cover that in renal. But the adrenal glands are very important to know in terms of their vasculature. So firstly, what are they? They are located on top of the kidneys. They also touch the diaphragm slightly. The right adrenal gland is pyramidal in shape, whereas the left gland is slightly semilunar in shape. I could never tell the difference in an actual specimen, but there you go. You can kind of see those shapes in this diagram here. It contains two functional components, which you will cover more in physiology, the cortex and the medulla. And the neurovasculature on the left and the right-hand side is slightly different, mainly the veins. So in terms of arteries, you've got superior, middle, and inferior adrenal arteries. They all come from different spots. So respectively, you have the inferior phrenic. The middle adrenal comes directly from the aorta itself, and then the inferior adrenals come from the renal arteries. Unfortunately, you just have to remember these because it can come up in exams or in specimens. When you get to the veins, the right adrenal vein drains directly into the IVC, whereas the left adrenal vein first drains into the left renal vein, and then the left renal vein drains into the IVC. And then nerves-wise, the adrenal glands are pretty interesting because in the medulla, those cells are actually modified postganglionic sympathetic cells, or sympathetic nerves, if you will, which means that they don't actually get postganglionic innervation, they just get preganglionic. So in other words, to simplify it, they get the preganglionic sympathetic nerve coming in. It innervates those medullary cells, which are going to be, in the end, releasing a bunch of catecholamines. Those medullary cells themselves are actually sympathetic nerves. So they don't need any postganglionic innervation per se. So the adrenal glands, while they might seem really small, they have a lot of really interesting and complicated neurovasculature, and a lot of these can be examinable. So I'd highly encourage you to sit down with this and try and memorize this as best as you can. And finally, the spleen, not very important when it comes to anatomy. The main functions, as you may know, are to filter blood, to create new red blood cells, as well as a potential storage place for platelets. The spleen normally lies between the 9th and the 11th rib, and it should move down during inspiration because it's right under the diaphragm, which will contract and flatten during inspiration. It's surrounded by a delicate fibroelastic capsule, which provides it some protection in fractures, but really, once you pierce that capsule, you hit the spleen, and the spleen is basically a blood bag. So that thing is going to rupture like anything, and you're going to lose a lot of blood. It also plays a super important role in infections, which is why when you have a splenectomy, for example, when someone has ruptured their spleen and you need to get rid of it, you will need to do some pre-surgical and post-surgical vaccinations for this person, because they're not going to be able to fight a lot of these especially encapsulated bacterial infections very, very well. All right, and finally, let's just cover the important neurovasculature when it comes to the gastrointestinal system. So hopefully you're still with me. We're gonna just quickly cover the arterial supply. So just to give you a bit of context, I'm gonna keep this diagram on the right-hand side there as I go through this. The three main branches of the abdominal aorta that we have are the celiac trunk, the SMA, the superior mesenteric artery, and the inferior mesenteric artery, in that order from superior to inferior. Now you can also see a couple of other branches that come off independent to these, and it's important just to know that they exist. But in terms of things that you want to remember for your exams and things that are a bit more important and less obvious are going to be the branches that come off each of these major trunks. So let's start with the celiac trunk. This is going to be the main supply to the foregut, as well as bits of the liver and the spleen. It comes off at the aortic hiatus level, so around T12, as you can see in the diagram there. The three major branches it gives off are the left gastric artery, splenic artery, and the common hepatic. And these each have their own branches, which if you want more information about, feel free to look at the notes or have a look at this diagram as well here. But in the end, all of these branches will combine and form the gastroepiploic and the gastric arteries. Of course, there's other branches going everywhere else as well, but these are the two main arteries that they will form in the end. And the stomach actually, so these arteries will supply the stomach, and the stomach basically receives supply from all of these three major branches, which is really, really interesting. So if I get obstruction of the left gastric artery, it's unlikely that my stomach is going to suffer a huge amount. Okay, and there's also that splenic artery behind that I would have talked about a couple of slides ago as well. So it's not just the stomach, it's also the spleen as well as bits of the liver. When it comes to the superior mesenteric artery, that's going to be supplying the midgut structures. It arises at the lower level of the L1 vertebrae, as you can see in the diagram on the right again. The major arteries that this gives off are the inferior pancreatico-duodenal. Superior pancreatico-duodenal actually comes off the celiac trunk, as you can sort of see in number 12 on the diagram there. You've also got the jejunal and the ileal arteries, which will supply the small intestines. And then you've got the middle colic, the right colic, and the ileocolic arteries. Some important things just to think about and potentially search up as well if you're a bit more interested in this, is that the jejunal arteries have less arterial arcades, which is difficult to show without a diagram. So I highly suggest you look this up, but it has longer vasa recta. So in other words, when we think about arcades, it's kind of like all the arteries sort of join up together and form these little triangles. It looks pretty cool when you look at a diagram. It has less of those, but it has longer vasa recta, which means it has longer parts of the arteries that just go out of those arcades and straight into supplying the intestine wall. With the ileal arteries, they have more arcades, so they have more of those little triangle bits, but it has much shorter vasa recta. So that means that it has less of a distance to travel before it reaches the actual intestines. You then got the middle colic, which is supplying the transverse colon. You've got the right colic, which supplies the ascending colon. And then you've got the ileocolic, which supplies the ascending colon, the appendix, the cecum, and the ileum. So in other words, remember that midgut means everything from the end of the duodenum to the splenic flexure. So you're not going to have anything here supplying the descending colon, because that's going to be with the next artery. Now, when we come to the inferior mesenteric, this is the major supply to the hindgut structures. This is at the level of the L3 vertebrae, again, as you can see in the right diagram there. The major arteries here are the left colic artery, the sigmoid arteries, and the superior rectal. So as I said, left colic is going to be the thing that supplies the descending colon, sigmoid is for the sigmoid colon, and superior rectal is for the superior 1/3 of the rectum. It's important to note as well that the SMA and the IMA will anastomose at a single point called the marginal artery of Drummond, which is at around the splenic flexure, because it's a watershed area, which I would encourage you to look up what that actually means. It's a very important concept when you get to next year, or like in any other system actually. Watershed areas are very, very prone to ischemia. So if you have some form of ischemic colitis, which means you have some obstruction which is preventing blood flow through these arteries, that splenic flexure, along with the recto-sigmoid junction, which is not really well shown here, will be places that are much more prone to ischemia and will probably die first, and then everything else will suffer as a consequence. Now, when we get to the veins, there's two main types of systems. We've got firstly the systemic veins. They drain basically into the IVC. Remember that the IVC, the inferior vena cava, is on the right-hand side of the abdominal aorta, just in case you need to distinguish them on dissection. Some of the major ones that I've identified here are the hepatic veins, common iliac veins, renal veins, the gonadal veins, the suprarenal veins, and then the phrenic veins. Most of these will follow your arterial supply, as you probably will be able to compare this red diagram with this blue diagram here. But some of these will also be a little bit different, as you will, as you might notice when it comes to, like, for example, as I've kind of said here, the veins that drain the gut actually go into the portal system rather than draining into the IVC directly. And the reason why is because if I go to the portal system, remember that the gut is the place where you have the absorption of nutrients. So all those nutrients first need to go to the liver to screen for toxins, as well as to absorb some of those extra nutrients into the bloodstream before we can then take that blood into the IVC. So it's super important that it goes to the liver first. and to the hepatocytes in the liver. So the portal system is composed of 3 main veins, and they drain the spleen, the pancreas, gallbladder, and a lot of the GI tract. The portal vein itself is formed from the union between the splenic and the superior mesenteric vein, as you can see in purple and in red on this diagram. And the inferior mesenteric vein will join up with the splenic vein separately. And all of these will then go straight into the liver, and then from the liver, they will go into the IVC. Note that the only exception to this portal vein system is the right and left gastric veins. They will tend to directly drain into the portal vein rather than first draining into, for example, the SMV or the splenic vein or the IMV. A lot of them will have the same name as the artery that they go along with as well, but they might have a different shape. And the classic one is the splenic vein. So the splenic artery is nice and straight, whereas the splenic vein tends to be a lot more tortuous. All right, and then you've got the portosystemic anastomoses. So as the name suggests, they are the anastomotic links between the portal system and the systemic venous circulation. The 4 main areas that you want to be thinking about are the esophageal anastomoses between the esophageal branch of the left gastric and the azygos vein, the rectal, which is the superior rectal of the inferior mesenteric vein and the inferior rectal of the internal iliac, paraumbilical, and then retroperitoneal, as well as one really small one on the bare area of the liver with the phrenic veins there. Now, unfortunately, you will have to remember all of these. So like you will have to remember what the anastomosis is actually in between, as well as the 4 major areas. The most important one, if you don't have as much time or you want to commit one really to memory, is going to be the esophageal portosystemic anastomosis. And the reason why is because for all of these, if you think about portal hypertension, which can be due to liver pathology, but it can be due to a bunch of things. When you have hypertension in the portal system, all that blood is going to backflow into the systemic circulation, and you're going to have all of these anastomosis areas start to become really engorged and then eventually rupture if things get really bad. And when you have an esophageal anastomosis rupture or an esophageal varices, you basically have a huge amount of blood that's going to then enter into the esophagus, and that's life-threatening, not only because of the blood loss, but you also get obstruction of the esophagus. Same with the rectum, you can get bleeding through rectal varices, and there's a distinction between rectal varices and hemorrhoids, which I'd encourage you to have a look at, but you can get bleeding from the anus because of that sort of hypertension as well. And then of course, paraumbilical, you can get bleeding around the umbilicus, retroperitoneal bleeding as well. Now, in terms of innervation, it gets really, really confusing. I'd encourage you to read over this diagram and look at this table again and again and again as you encounter questions on this. But I've tried to simplify it as much as I can for you guys by showing you that all of these will follow a similar pattern. So the sympathetic innervation is conveyed through splanchnic nerve. So they don't directly come off of the sympathetic chain. They actually kind of, firstly, they start in the spinal cord. They go to the sympathetic chain, but instead of kind of coming off of that directly, they continue onwards as a splanchnic nerve, and then they will innervate or kind of link up with something at a ganglion, and then you get your postganglionic nerve, if that makes sense, right? So you'll have a whole lecture on this, but this is just a brief overview of how that works. We've got the greater splanchnic nerve, which comes from T5 to T9, and that's going to supply all of your foregut structures. That goes from the great splanchnic nerve into the celiac ganglion there, through the celiac plexus, which is what this represents, and it actually travels along with the celiac artery. So all of them sort of make sense together. The lesser splanchnic nerve, T10 to T11, supplies all of your midgut structures. It goes through the superior mesenteric ganglion, through the superior mesenteric plexus, and it goes with the superior mesenteric artery. So again, they all link up together. The least, or it's kind of a weird name, right? Least splanchnic nerve, because I guess they already used the word lesser somewhere else, is T12. It mainly supplies the kidneys and the ovaries, but of course there's exceptions. It again travels with the SM ganglion, the SM plexus, with the SM artery. When you get to the lower bit, so the lumbar splanchnic nerve, that's L1 and L2, that's all your hindgut structures. That will travel through the inferior mesenteric ganglion, with the inferior mesenteric plexus, with the inferior mesenteric artery. And then finally, the sacral sympathetic nerve, that's not so important for gastrointestinal, that's more important for pelvic. That's L1, L2 again, but I thought I'd just bring it up here just in case it gets a bit confusing. That again goes to the IM ganglion, but instead of going with the IM plexus, it will go straight into the hypogastric plexus, which we will cover in a lot more detail when you get to pelvic anatomy. Then you've got parasympathetic innervation, which is much, much easier because you've only got two nerves. Before the splenic flexure, or pretty, like if you think about it, it's all the foregut and midgut, you've got the vagus nerve. Vagus nerve literally goes everywhere. It has a lot of head and neck stuff, as well as, heart functions, but it also has parasympathetic functions in the gut. So all the way from the esophagus down to the splenic flexure. And then you've got the pelvic splenic nerves, which are S2 and S3 and S4. They go from the flexure down to the rectum. Now, an easy way to remember the difference between, like, for example, pelvic splenic and sacral nerves, and like, how do you tell the difference? Well, remember sacral nerve is S, right? So that's sympathetic. Whereas if you think about pelvic splenic, that's P, which is parasympathetic. So just an easy way to remember those. And then finally, somatic innervation, the only real place you need that is going to be with the external anal sphincter, because that's the only one you need control for. An easy way to remember the nerve roots is S2, S3, S4, keeps shit off the floor. And then somatic control it allows for somatic control of defecation when all of that food gets down to the bottom. All right. And then last bit is lymphatic drainage. I've only really put two diagrams here because it's not that important for you to know the ins and outs of the drainage itself. So this diagram is definitely just overkill. It's just to show you, like, it's a very, very complicated process, but in the end, all of the lymph will drain into the cisterna chyli, which you might remember when we did thorax, and then eventually they will drain into the thoracic ducts. The importance of this lymphatic drainage pattern is more so for the spread of cancer. So where would you expect, a splenic, like a spleen cancer to go to? Where would you expect a stomach cancer to go to? And speaking of stomach cancer, my question to you is, if you can look up what the first palpable lymph node would be in the case of a stomach cancer metastasis, that's super important when it comes to specimens and exams. So if you can identify that lymph node on an exam, as well as on clinical examination, if you notice that lymph node specifically is quite palpable and it's also quite large, then that raises your red flags for, oh, does this person have a potential stomach cancer? So I've put the lymphatic drainage of the stomach here as well, just for context, if you want that to help you with the question that I've just posed. But that's pretty much it. So thank you everyone for sticking around. I know this was a really, really long lecture, but hopefully this will set you up really well for everything you need to know with regards to gastrointestinal anatomy. So it should last you for the next 2-3 weeks. If you want a bit more detail though, and you're a bit interested in figuring out some of the more complicated niche things when it comes to these topics, I recommend that you look in the comments of these slides. I've actually put on a couple of slides a few questions that link up to clinical correlates. So for example, when we were discussing the arterial supply of the gut, one of the questions that I had in the comments in these slides is, which of the arteries do you think would be affected if you had a rupture of a peptic ulcer or a duodenal ulcer? Because again, that's been asked before, and it's quite easy to intuit once you have a good understanding of the anatomy. And I've got a whole lot of those goodies in the comments if you want to have a think for your exam revision. And I've also got the link, as I said, to the notes that I've uploaded onto the drive if you need some extra supplementary material. As always, let me know if you have any questions, or if there is anything on these slides that confuse you. I can try and add in a couple more resources or post another video explaining those. But otherwise, best of luck for all of your seminars, and I hope to see you in another video. Cheers.